So once, should I start?
Yes, Dr. Arpita, please start. Please start immediately so that we are not delayed, and you send a message for everyone to join as soon as possible. Thank you.
Yes, yes, definitely. A very good afternoon to one and all. I, Dr. Arpita, welcome you all to yet another day in our webinar series on recent advances in pediatrics. I hope everyone is enjoying our sessions and getting benefited by them. So after our sessions on intensive care and neonatology, we'll be updating our knowledge on neurology today. So without much delay, I feel so honored and privileged to call upon our first speaker, Dr. Chandrakanta, Professor and in charge of Neurology Clinic, Department of Pediatrics, King George Medical University. I welcome you, ma'am. Ma'am will be discussing about newer antiepileptic drugs. Welcome, ma'am.
Thank you, Arpita, for this nice introduction. And I thank Shelly ma'am for organizing this webinar and to allow me to speak on this topic. So I welcome all the participants, and I will be talking about the newer anti-epileptic drugs in pediatric epilepsy. I hope my screen is visible and my voice is clear.
Yes, ma'am.
So I will be talking about the newer anti-epileptic drugs in pediatric epilepsy. Some are new and some are actually we are already using them and we are familiar with them. And to keep my talk concise and easily understandable, we will not go into a very detail of pharmacology and pharmacokinetics of these drugs. So we will discuss in brief. So as you know that the epilepsy is a chronic pediatric neurological disorder and the risk of recurrence persists lifelong. And it has a huge burden. So WHO estimated that around 50 million people suffer from epilepsy and half of them are children or adolescents. So around 25 millions of children and adolescents, they suffer from epilepsy. So this is an important topic to discuss. And we know that there are various modes of, there are various modalities of treatment of epilepsy, but the main and the first thing is the use of anti-epileptic drugs, and other modalities are limited and availabilities is limited, like ketogenic diet and surgery. So in our situation, they are hardly available to the general population. So we mainly depend on the use of anti-epileptic drug. So when we use anti-epileptic drug, the aim of starting any drug is that we control the seizure completely. But we have to keep in mind that the adverse events are not there or they are minimum. So we have to minimize the adverse effect of the anti-epileptic drugs because we are always using them for a longer duration. So if we are using a drug for 2 years, 4 years, 5 years, then the side effects matter a lot. So in this talk, we will discuss the newer anti-epileptic drugs in brief. And if time permits, then we will discuss that how to use them in some common epilepsies in children. So these are the anti-epileptic drugs which are available. So the first generation, second generation, and the third generation, 3 generation epileptic drugs are available. So till the valproate, it's a first generation anti-epileptic drug, and after the introduction of valproate, the other drugs which were developed, they are called newer anti-epileptic drugs, the second generation and the third generation anti-epileptic drugs. And this is the time limit after 1970 to 2007, they are second generation, and after 2007 drugs which were developed are third generation anti-epileptic drugs. So we have second generation anti-epileptic drugs like Clobazam, Vigabatrin, Oxcarbazepine, Lamotrigine, Gabapentin, Clobazam, Topiramate, Vigabatrin, Levetiracetam, Prescribing, Zonisamide, Stiripentol, and Rufinamide. And the third generation drugs are Oxcarbazepine, Lacosamide. Okay, so we are not going to discuss this. This is withdrawn. Perampanel, everolimus, Vigabatrin, and cannabidiol. So we'll discuss in brief. So first, the newer antiepileptic drugs, mainly they are used as an add-on therapy. They are not used as a first-line drug, but with time, more and more people are using them as a first-line drugs also, and some are actually now indicated as a first-line therapy also. So they are useful, but they are not more effective than our previous conventional anti-epileptic drugs. But they have a better safety profile, they have less interaction with the other drugs, and the side effects are less. But it doesn't mean that we can use them whenever we want, because they also have side effects, and some may be even severe. So they are not free of side effects. We have to keep in mind. They don't have enzyme induction, so there is minimal drug interaction with other anti-epileptic drugs and the other drugs like antitubercular drugs. But they are more expensive. So if we are adding one drug or two newer drugs to the therapy, then the cost matters a lot. So we have to think before we start. Okay. So first, in brief, I will discuss newer drugs one by one, and then we will see that how to use in different situations. So the first drug is Oxcarbazepine. We are all familiar about this drug, and this is one of the second line anti-epileptic drug which we can use as a first line drug, and actually it is indicated as a first line drug for focal onset seizure. So we should think about starting Oxcarbazepine before starting carbamazepine, but it is costlier than carbamazepine. So it acts by blocking high frequency voltage dependent firing of sodium channels. So it is same, it is used for focal seizure like carbamazepine, but the side effects are less because it is not metabolized to the epoxide derivative, which is cause of side effects of carbamazepine like skin rash, hyponatremia, headache, dizziness, and ataxia, and it has less interaction with the other drugs. So the dose is, we start with the 5 to 8 milligram per kg per day, 2 divided doses, and we gradually increase on weekly basis and maximum up to 30 milligram per kg. So this is another second generation anti-epileptic, and we are all familiar with Clobazam and we are using it. It is benzodiazepine derivative. It acts on GABA receptors and increases the efficacy of GABA, and it is a broad spectrum anti-epileptic drug. So though it is a broad spectrum anti-epileptic drug, we can use it in all the types of seizure like refractory, partial seizures, generalized absence, and myoclonic. So it is active in all the types of seizure, but it is mainly indicated for Lennox-Gastaut syndrome in about 2 years of the child, age of the child, and it has a synergistic action with valparin. So we often use valparin in Lennox-Gastaut syndrome, and if we add clobazam with this Clobazam, then there is synergistic action and both are more effective. The side effects are mainly sedation, other may be mood swing, irritability, depression, aggression. The dose is, we start, if the child weight is less than 30 kg, we start with 5 mg per day and gradually we increase up to 20, or we can use up to 1 milligram per kg maximum. This is another second generation anti-epileptic we have all used, that is Levetiracetam. It has a special mode of action by acting on SV2A synaptic vesicles and also acts on the calcium channels. Okay. This is another broad spectrum anti-epileptic drug, and it can be used in all the types of seizures, okay, both partial seizure and generalized seizures. And it has a minimum drug interaction, so it's safe in liver diseases and it has intravenous preparation available. We are all using it as status epilepticus, control status epilepticus. When valproate is contraindicated or status is low. Side effects are less with Levetiracetam, and it is considered as a safe drug. So many people are now using it as a first line drug, not an add-on therapy. So side effects may be headache, anorexia, and drowsiness. And main concern is in children with autism and this global developmental delay. It may cause behavioral problem like aggression, psychosis. So we have to don't use this in children with autism, and use with caution in global developmental delay. So starting dose is 10 milligram per kg, and we can increase it every 2 weekly and go maximum up to 60 mg per kg per day. Lamotrigine, again, is second generation anti-epileptic drugs. It acts by blockade of the voltage dependent sodium channel, and it is also a broad spectrum anti-epileptic drug, but mainly used as in add-on therapy for refractory partial and generalized epilepsy. This can be used for absence seizures and myoclonic seizures, and particularly in Lennox-Gastaut syndrome, it is useful. May be used as a first-line therapy for idiopathic generalized epilepsy. So lamotrigine is actually a broad-spectrum anti-epileptic drug. It can be used in myoclonic seizure, but we have to be cautious that this can actually precipitate or increase the myoclonic seizures. Okay, so this drug has been used in juvenile myoclonic epilepsy, in children with Lennox-Gastaut syndrome, but occasionally this may precipitate myoclonic seizures, so that we have to keep in mind, and particularly in patients with Dravet syndrome with myoclonic seizure, we don't use lamotrigine. Okay, so we have to use lamotrigine with caution in myoclonic seizure. Again, in West syndrome, we don't prefer this for the same reason, but we can use it with caution. So side effects, this is a well-tolerable drug. So side effects are minimum, like drowsiness, sleep disturbance, diplopia, ataxia, nausea, and vomiting, but they are less, and it is easily tolerable drug. The main problem is the chances of Stevens-Johnson syndrome and toxic epidermal necrolysis and skin rash with lamotrigine, and that can be life-threatening. Okay. So we have to use it with caution, and we have to increase the dose very gradually to avoid this complication of Stevens-Johnson syndrome and 10. Okay. So we start with 1 to 2 mg per kg, and if you are giving with valproate, then you start with 0.5 milligram per kg and increase the dose after every 2 weeks very slowly. We can go up to 8 mg, some go up to 15 milligram per kg per day. But if we are using it with valproate, the dose, maximum dose is 5 milligram per kg per day. So it's always advise your patients that when they are starting with this drug or we are increasing the dose, if they see any rash, then they should immediately report or stop the drug. So with increasing dose very gradually and with this precaution, I have never seen a child developing Stevens-Johnson syndrome taking lamotrigine. But we see skin rash, and often the attendants, they stop it or they report, and it is stopped timely, so they don't develop Stevens-Johnson syndrome. So this is a drug which we have to increase very gradually when we are giving, and we have to be cautious about this drug. Otherwise, very well tolerable, It has a broad spectrum antiepileptic effect, so can be used in all the seizure type except in Dravet. Topiramate, again we are all aware about this drug. So this acts on voltage-dependent sodium channel, on GABA receptors, glutamate, and also acts by inhibiting carbonic anhydrase. So this is a specific mode of action of topiramate. So this acts on multiple sites and it is a broad spectrum antiepileptic drug. It is particularly used as a therapy in children with West syndrome. So this is a very good drug for infantile spasm, a good drug for refractory epilepsy in Lennox-Gastaut syndrome. But otherwise, you can add this drug to any child who has refractory partial or refractory generalized epilepsy. So this drug is useful for partial generalized epilepsy, for myoclonic seizures, and for absence epilepsy also. So the side effects are mainly dizziness, mental slowing, ataxia, impaired concentration, confusion. Otherwise, it has a good safety profile, but to my experience, because we are using it mainly with the valparin, it causes a lot of sedation. And a lot of patients, they report the fever or increasing temperature because it is carbonic anhydrase inhibitor. This decreases the sweating and can result in hyperthermia. It can result in metabolic acidosis and nephrolithiasis. So these we have to keep in mind, but this is a good drug for infantile spasm, for Lennox-Gastaut syndrome, and as an add-on therapy for refractory partial and generalized epilepsy. We have to use this drug with caution when we are using with topiramate. This can cause encephalopathy and hyperammonemia. So starting dose is 1 to 3 milligram per kg, and which should be increased slowly, and maximum we go up to 8 or 9 milligram per kg per day. Okay, so next drug is Zonisamide, again a broad spectrum anti-epileptic drug. Acts on dopaminergic receptor, serotonergic neurotransmitter, calcium channel, sodium channel, and this is like topiramate. This is also inhibitor of carbonic anhydrase. So this has those side effects which topiramate also has, like hyperthermia or nephrolithiasis, fever, oligohydrosis. So these complications are like the complication of topiramate. So for this reason, we don't combine Zonisamide with topiramate. So Zonisamide is again a very good drug, frequently used for infantile spasm, and this is a good drug for drop attacks and other seizures in Lennox-Gastaut syndrome. So these are the two common indications for which we are using Zonisamide, the infantile spasm and Lennox-Gastaut syndrome, but we can use in myoclonic epilepsies also and progressive myoclonic epilepsy syndrome. Okay, so it acts on almost all types of seizures, but we have to keep in mind the side effects, and particularly don't combine Zonisamide with the topiramate. Use only one. So the dose is almost like topiramate. We start from 2 to 4 milligram per kg per day, and then we gradually increase to 4 to 8 milligram per kg per day. So these are the second generation anti-epileptic drugs which we are using. They are mostly broad spectrum. So now coming to those second generation anti-epileptic drugs which are indicated only for a specific situation. Okay. So these drugs are, one is Vigabatrin. Vigabatrin acts by enzyme GABA transaminase, and we all know that this is the drug which we are using in infantile spasm or West syndrome. Okay. So in West syndrome, we know ACTH is the first drug of choice, but if the child has tuberous sclerosis, then Vigabatrin is more effective than hormonal therapy almost 3/4 they become spasm free. So this is the first drug when there is tuberous sclerosis with West syndrome, and in other types of West syndrome, if the child is not responding to ACTH, then we should use Vigabatrin. So this is a second line therapy. But the problem is the cost of drug. So, and the availability. It's not freely available in the market and it is very costly. So in our practice, we are not using it as a second line drug, and we are using mainly with the refractory infantile spasm because of availability, and the patients, they don't afford it because of cost. So this is the only indication for which it is indicated in children, but otherwise it's also effective in the partial seizures. And it should not be used with the myoclonic seizures and absence seizures, may cause worsening. It has a good oral bioavailability. The drug interaction are minimal. So it's well tolerable, but because of one serious side effect, it is not used frequently, and that serious side effect is bilateral concentric visual field constriction. And we know that in small children, like in West syndrome, even vision assessment is difficult. So how to assess the field restriction that the drug is causing side effect? So because of that, its use is limited to West syndrome only. So dose is 50 milligram starting dose. We can go up to maximum 150 mg per kg per day, and this drug we increase little bit rapidly to see the effect. And because this is a toxic drug and has a side effect of visual field defects, we don't give for a 2 years or 3 years duration. So this drug we give for a short duration. So mostly we stop after 3 months or 6 months in West syndrome, and it is not prolonged beyond 6 months. And it has been seen that the first sign of visual field restriction in adults mostly appears after 6 months of therapy. So till then we can use it probably safely. And if it is not, there is no effect observed on infantile spasm, it should be stopped quickly within 2 weeks to avoid this complication. So Rufinamide is other second generation anti-epileptic drug, which is indicated only for a specific situation, that is refractory Lennox-Gastaut syndrome. So this is the only indication of Rufinamide. Its mechanism of action is not fully understood. It can act on other type of seizure also, like partial seizures and other refractory and epileptic encephalopathy, but it is to be used only in refractory Lennox-Gastaut syndrome. So we start with 10 milligram per kg and go up to maximum 45 milligram per kg. The adverse effect of this drug is headache, dizziness, fatigue, and nausea and drowsiness. So Stiripentol is the other second generation anti-epileptic drug used for only a specific situation, and this drug is used only in cases of Dravet syndrome or severe myoclonic epilepsy of infancy. This acts at GABA transmission and it has serious side effects: GI, CNS, respiratory, skin, hepatic side effects. So it is useful drug for other type of seizures also, but because of this serious side effect, it is used only for refractory Dravet syndrome. So other second generation anti-epileptic drugs are Gabapentin, which can be used as a drug for partial seizure above 12 years. Tigabine again for partial seizures above 12 years. Pregabalin, people are not using it frequently, can be used for partial seizures. Clobazam is a broad spectrum anti-epileptic drug, can be used for Lennox-Gastaut syndrome, but now it is not used because there is a risk of aplastic anemia and liver failure. So So these are all the second generation antiepileptic drugs, and there are few third generation antiepileptic drugs. Some are in market, some are not available in India. So third generation antiepileptic drugs are the drugs which are rapidly introduced in pediatric epilepsy. Like the data, safety data is extrapolated from the adult studies. So there are not so much studies about the safety of the third generation epileptic drugs in children. The safety data is extrapolated from the adult studies. So we should not jump to the third generation anti-epileptic drug. We can use in those children who have refractory epilepsy. Okay, but as they become available and we use more and more, maybe we will be using them as a first line drug also in coming time. So these drugs are, one is Clobazam, as the name suggests, like carbamazepine, it acts as sodium channel inhibition, and it is approved by FDA in 2017 as an adjuvant treatment for focal onset seizures in children above 4 years. So second line drug, you have seen that mostly were broad spectrum or indicated for a specific situation. The third generation anti-epileptic they are mainly recommended as of now for refractory partial seizures. Okay, so this drug is for partial seizures above 4 years of age. The starting dose is 10 to 20 milligram per kg. We can go up to the 60 mg. It's oral drug, and the side effects are same like carbamazepine, but are less. So this is another third generation antiepileptic, Lacosamide, an interesting drug because it has available intravenous preparation. So intravenous preparation of Lacosamide is available. So this is a potential drug to be used in children with status epilepticus and in adult patient with status epilepticus. So this acts by inactivation of sodium channel, and it is approved only in children above 4 years of age by FDA in 2017. The starting dose is 2 milligram per kg per day. We can go up to 12 milligram per kg per day. So till now I have not used this drug. This drug is available in India, but I have used only in one patient, that was the Wednesday team patient of refractory, super refractory status epilepticus. Okay, so not responding to even general anesthesia, refractory partial seizure. General anesthesia was given, propofol was given, and the child finally responded to Lacosamide. So I hope in future we will be using more and more of this Lacosamide for refractory focal seizure presenting with status epilepticus. So this is third generation antiepileptic drug, Perampanel. So this drug is broad spectrum, but as of now, this is recommended for focal seizures only in children and was allowed in 2018. It acts on AMPA-glutamate receptor. It is antagonist. It is broad spectrum, but indicated in focal seizure. The starting dose is 2 milligram per kg, maximum is 12. And the side effects are dizziness, drowsiness, aggressiveness, irritability, loss of appetite. So the next is everolimus. This is actually not an anti-epileptic drug. So this is mTOR pathway inhibitor, and this drug was first used in tuberous sclerosis for SEGA or astrocytomas associated with tuberous sclerosis. It was found that it reduces the growth, but now it is recommended for tuberous sclerosis children who has drug resistant focal seizures. The starting dose is 5 milligram per meter square. We can go up to the 15. Oral preparation only, and the side effects are actually many. So we have to reserve this drug only for refractory epilepsy in tuberous sclerosis. Vigabatrin is like Levetiracetam, and can be again used as a broad spectrum, but as of now, it's used only for focal seizure. Acts like Levera or SV2A receptors. Starting dose is 1 to 2, maximum up to 5, and this is also available as intravenous preparation like Levetiracetam. And this is the latest addition into the list of drugs. Okay. Cannabidiol. This is a derivative of cannabis plant, and this drug should not be confused with those Ayurvedic preparations which are available in India. So its drug is not available in India. It acts probably by modulation of GABA receptor. So this is the drug for which I think maximum number of trials are going on in epilepsies and refractory epilepsies. Okay. And this drug is now approved for pediatric patients in Dravet syndrome and Lennox-Gastaut. So only in severe refractory LGS and Dravet syndrome, this drug is allowed, but it is still not available in India. Okay, so starting dose is 5 mg, we can go up to 20 mg. The side effects are sedation, fatigue, anorexia, and diarrhea. Okay, so this is the relative cost of the drug. So we see that in comparison to your standard drugs, these newer drugs are costly. So these are the second generation and third generation antiepileptics and how to use them. Okay, so when we are prescribing antiepileptic drug to any child, we have to individualize the treatment. Like for a very poor patient, we are not using Phenobarb now, but if a patient is very poor, then can still use Phenobarb. So we have to individualize the treatment. Use only one drug. So this is a common thing we see in practice, that 2-3 drugs the child is taking and all in starting doses. So use only one drug as much as possible. Start with a single anti-epileptic drug. Start with a low dose and increase gradually. And before switching to the other drug or increasing the dose, ensure compliance. Increase the dose gradually and look at the comorbid condition, and when there is refractory epilepsy, so we keep on adding drugs, and finally the child is on 5 drugs or 6 drugs. So this we have to avoid. We have to not only see the freedom from seizure, but also the quality of life. So if quality of life is better with few seizures and 3 drugs, then seizure-free status with 5 drugs, the 3 drugs with seizure is better. Okay. So target should be realistic, like Lennox-Gastaut, Dravet. There hardly we are able to control fully. So this has to be explained. We can tolerate brief seizures to reduce the side effects, and usually we taper after 2-3 years of seizure-free period. Okay. So this is this slide shows you that in which type of seizure we can use which drug. Okay. So like tonic seizures, we can use Valproate, Rufinamide, Clobazam, Lamotrigine, broad spectrum drugs. In broad spectrum, you know, all the second line drugs, they are broad spectrum, and the Valproate is broad spectrum. In third generation, Perampanel is broad spectrum. For infantile spasm, we use ACTH, Vigabatrin. For absence, Ethosuximide is drug of choice. So we are not using this drug because it was not available in India. But for last 2-3 years, this drug is available and we can use. So this is the first line drug. But for atypical absence, if there are any other associated type of seizure, then Valproate is better preferred. Myoclonic seizure, primarily generalized seizure, we use broad spectrum drugs. For focal seizures, Carbamazepine, Oxcarbazepine, Vigabatrin, Phenytoin, Gabapentin, and the newer drugs, third generation drugs we can use. So if we are using more than one therapy, then they should be having different mechanism of action, and it's always better to combine one conventional with a one new drug. Two conventional drug will have more drug interaction. So one conventional drug and add the newer anti-epileptic drug. So two drugs used together will not should not have drug interaction, possibly do not have similar side effects like Topiramate and Zonisamide, and some drugs have synergistic action, so they are better. Okay, like Vigabatrin with Lamotrigine, more effective. Vigabatrin with Topiramate and Clobazam. Oxcarb with Topiramate. Oxcarb with Clobazam. Or Zonisamide with Clobazam. So, Arpita, do we have questions? Some questions till now?
Yes, ma'am. One question is there.
Okay.
Ma'am, should I say the question? Kindly tell which newer anti-epileptic drugs can be used
line only. Okay.
as an add-on drug. Which drug should be used?
Lamotrigine, Oxcarbazepine. Okay. But different people are using different drugs. So I have seen even people using Topiramate as a first line drug. So depends on experience also. So there is no more questions, so we can discuss one or two case scenario.
Yes, ma'am, definitely. We have time.
Okay. So please tell me when I need to stop.
Yes, ma'am.
Okay. Okay. So this is a case scenario. We are all familiar with this. A child presented with generalized tonic-clonic type of seizure. History was generalized tonic-clonic type of seizure. MRI is showing NCC, EEG is non-specific focal slow waves in the same area, frontal area. So which type of epilepsy is this? The residents should answer this question quickly.
So residents can write in the chat box.
Please write in chat box. Which type of epilepsy is this? Focal, generalized or mixed? I think recently there was a seminar on classification of seizure and epilepsy. Okay, so this is a focal epilepsy because there is a focal lesion MRI brain. There is no epilepsy syndrome, and which drug we can use? First line drug?
Open to all.
So first line drug should be carbamazepine. Okay, and if affordability is not an issue, then oxcarbazepine we can use as a first drug. Okay, and there are a lot of other options. What are other options? So there are a lot of drugs in third generation, but we don't use them routinely. So other maybe phenytoin, the broad spectrum, Levera, Vigabatrin again effective, but we are not using. Okay. So this is the second case scenario. A 10-year-old child presented with 2 episodes of seizure. Okay, so first seizure was 16 months back, then there was second seizure. During seizure, there were focal movement of the face and the upper limb. There was a lot of drooling and gurgling sound during seizure. Both the time occurred during sleep. MRI was normal and EEG was showing bilateral centrotemporal spikes. Okay. So what do you think? What is the type of seizure? I think it is clear. It is focal. Type of epilepsy in this child? or which epilepsy syndrome will you suspect?
I have an answer from Devina.
There was one answer, JME. JME is not. So this is focal seizure. So this is the example of the most common epilepsy in children, that is Rolandic, okay, or epilepsy with centrotemporal spikes. Okay, so should we start anti-epileptic drug in this child? Okay, Bex is the right answer. Somebody has written. Should we start anti-epileptic drug, and which drug we should start? Hello, voice is not clear. You can write in chat box. I can't hear. Okay, so if we see that though EEG is abnormal, but look at the gap between first seizure and the second seizure, 16 months, so infrequent. So if second seizure is occurring after 1 year of gap, then starting anti-epileptic drug is not, we should not start anti-epileptic drug. So we should wait for another recurrence. Though EEG is abnormal, but this hints towards a self-limited or benign type of epilepsy. For this type of epilepsy, drug is not required if you can adequately counsel the parents, because they are brief seizure occurring only in night, not causing any harm to the child and otherwise not causing any problem. So it's not mandatory to start the drug even in multiple seizures in this situation. Okay, but if we want to use, what are the drugs we can use? So like focal seizure, carbamazepine, oxcarbazepine, Levira and Vigabatrin. These drugs are commonly used in epilepsy with centrotemporal spikes. Okay, so should I stop here, Arpita? I think we should stop here.
We can take
and this
one
case scenario we'll discuss.
We can take one more case scenario.
One more.
It's interesting.
Thank you. So I think this we are all familiar. A child with perinatal asphyxia presented with startling episode, causing flexion of all the limbs, persisting for only few seconds, occurring in clusters, and there is some regression. Okay, so regression and MRI, EEG showing background abnormality, multifocal discharges, electrodecremental response. I think all of you must have seen these type of patient in your OPD when you are coming to neurology OPD. So what is the type of epilepsy syndrome here? Okay, so everybody is right. West syndrome. Okay. So which drug? First line. First line drug. ACTH, very good. Second line drug. Okay, second line drug is Vigabatrin. Other options? Okay, so after ACTH and Vigabatrin, Valparin, other drugs? Second line drugs which we discussed: Valparin, Topiramate, Zonisamide, Levetiracetam. You can also add Frisium. Okay. So next is the same case, improved with the treatment, but at the age of 3 years developed multiple drop attacks, infrequent generalized tonic seizure, mostly in night, and also there were multiple episodes of steering look during the day, and EEG showed slow spike wave discharges of 2 to 2.5 Hz. Okay, so what is the type of epilepsy syndrome here? Quickly. Absent seizures, no. Lennox-Gastaut, good. Okay, so Lennox-Gastaut is, they classically have drop attacks, nighttime seizures, tonic seizures, nighttime tonic seizures, and drop attacks. And they have multiple types of seizures. So all the type of seizures they can have: absence, myoclonic, drop attacks, tonic seizures, and EEG will show slow spike and wave discharges. Okay, so what drug you want to start in this case? Quickly. LGA's first drug. Okay, so Valparin, good. Valparin is usually the first drug. What are the other options to add if the child is not responding? Zonisamide, good. Topiramate, good. Okay, okay. Clonazepam, Clobazam, Levetiracetam are other option, but there is a specific drug for this situation for refractory LGS. What was the name? Name of the drug is specifically indicated for LGS. We discussed it. That is Rufinamide. Rufinamide. Costly drug and availability is the issue, but it is a good drug. So I think I should stop here. So to conclude, most of the newer antiepileptic drugs, they have been tested as add-on therapy for drug-resistant epilepsy. They can be used as first antiepileptic drug in specific situations. They have better tolerability and pharmacokinetic profile, but they are not more effective than first generation. We have to still look for the side effects, and we can use Oxcarbazepine and also the Lamotrigine, Levira as the first line drug. And the cost is the main factor which limit their use. So thank you everyone for your patience listening.
Thank you so much, ma'am, for such an excellent talk and updating us on the newer antiepileptic drugs too, and making it more interesting with the case scenarios you discussed. Ma'am, I think we missed one of the queries by our participant regarding case 1. She's asked, for generalized seizures, can carbamazepine be used?
Okay, so case 1 was the child seizure semiology was generalized tonic-clonic type of seizure. Okay, so this is the new thing in classification of epilepsy, that you can use EEG finding, you can use MRI finding to classify the type of epilepsy. So seizure semiology is generalized, but imaging and the EEG findings suggest that this is a focal one. So final classification of this child is a focal epilepsy. So we should use because focal epilepsy we are using narrow spectrum AD, and like for antibiotic, the narrow spectrum is better if we can use than the broad spectrum antibiotics. So in this situation, the narrow spectrum Oxcarbazepine will be good.
Thank you so much, ma'am, for clearing the doubts. So we move on to our